Recording in progress.
Welcome everyone to Wildcard Wednesday. It is May 27th, 2026, and I am Stacy Buck, President and Senior Consultant at RadRx. So this week we have two lower extremity cases that we're going to take a look at that present a little bit of a challenge, mostly because of documentation, which a lot of cases that we look at Wildcard Wednesday, we're breaking down documentation issues. But before I get into today's cases, I wanted to remind everybody, if you have any cases, to please submit them at the radrx.com website. I have the direct link here on the screen, but if you simply go to radrx.com and then look for the contact us button in the right corner, top right corner of the screen, you can click on the contact us button. It will open up the submission form, and then you can copy and paste your case information there. Just please make sure that you're not sharing any patient information when you submit the case. So I think I only have one left in the queue to do like next week. So please start sending in more cases. I've caught up with the ones that had been submitted over the past probably 6 to like 8 weeks or so, but I could use some more cases going forward. Okay, so let's jump into our two cases for this week. So in our first case here, so I had the person sent in information about a consult that was done before the procedure with this. And the specific question that was asked for this case, it was about the two access points in the procedure. Can we bill the ultrasound guided vascular access twice? And then mentioned the first access, with the advancement to the tibial vein, and then the second access to the iliac, and then listed the catheterization codes. And can we bill for both as two separate accesses? So also asking about that. So the catheter codes that were actually submitted as part of that question actually are not the correct ones, and I'm going to explain why the catheterization codes are what they are in this case. So let's go ahead and jump into it. So here we see in this consult initially, we see, we discussed the role for catheter-directed intervention in this setting of extensive DVT findings, the goal of the procedure. We see down here, venography with plans for TPA was discussed with the patient. So reading this like first paragraph, it seems like, okay, they know what they're doing. They've established a diagnosis. They're moving, forward with an intervention. But when we jump down here to these bullets, the first bullet point says proceed with venogram with possible angioplasty, stenting, thrombolysis, thrombectomy, and or IVC filter placement with procedural sedation. So here we have a bit of a conflict in the documentation. So the initial paragraph, I would have said, no, we're not going to code for the diagnostic imaging. And then coming here, if I just saw this statement and I hadn't seen the paragraph from the consult, I would have said, then we're going to code for the diagnostic venography in this case. So this is probably one that I would do a little bit more detective work on, looking in other parts of the medical record to confirm what was known and exactly what the plan was, since we actually have the two conflicting statements before assigning the imaging code. So FYI, that's what I would do with this. I would do a little bit more research, possibly ask the physician if necessary to determine whether or not it should be coded, because I don't want to be coding it, obviously, if I shouldn't be. But then, of course, I want to be able to code that if it's appropriate to do so in accordance with all of the rules for reporting diagnostic angiography, which I've gone over many times in past episodes. So here, again, I'm going to, like I usually do, I like to look at the procedure list first to give me a feel for what we're doing. So we have access at the anterior tibial vein, venography of the left extremity, another access at the left popliteal vein, angioplasty of iliac veins, femoral popliteal venous system, and then thrombolysis initiation. And so now we're going to get into the procedure. So monitored conscious sedation, it's mentioned in the report. We don't have any time noted. So we would want to go find that time somewhere. I'm pretty sure it was at least 10 minutes to meet that 10-minute threshold for 99152. But since we don't have the total time, we would want to go find that elsewhere in the medical record and then make sure that we're coding the 99152 and 99153 as appropriate. So when we jump down into the procedure details, we see in this first paragraph here where we have the ultrasound evaluation of the anterior tibial vein. That's documented like there, and we have our documentation requirements, mentions the patency. We see visualization under ultrasound guidance, and then we have the image documenting needle position like archived. So we have our documentation requirements for 76937. So at this point, the access at the anterior tibial vein, we have that direct puncture. Right now, we have a 36005 for our catheter placement code. The catheter has not moved at this point. Next paragraph, the physician mentions that, they couldn't aspirate any blood. A gentle injection was attempted, but contrast did not traverse a few centimeters beyond the tip of the sheath. And then finally was able to cross the distal thrombus in the tibial vein, went to the mid-tibial, and then said easily traverse the mid-distal portion of a vein and a presumed, I was then in a patent vein again. And then contrast was injected, verifying this. So at this point, even if we were considering documenting, or coding potentially for diagnostic venography, at this point, I'm not even quite sure that this reads as diagnostic. The contrast is basically being used to, okay, I injected and now this is where I'm at. This is like a location. So I wouldn't consider that diagnostic, even if if we did find out we were able to code the diagnostic venography. And then goes on to mention an occlusion. There, the tibioperoneal veins cross the anterior tibial into the below knee popliteal, but couldn't make any progress from that point. So at this point in the procedure, the physician decides, okay, I need to get a second access, and I'm going to do that through the popliteal like vein there. So the catheter code has not changed. The catheter was actually moving up the extremity. So the puncture was at the anterior tibial, and then the catheter is going up the extremity, up the extremity, up the extremity, moving in the direction of the inferior vena cava. So with your catheterization codes, if the physician has the puncture like way down in the extremity, in this instance, the anterior tibial vein, or if it was the posterior tibial vein, you don't actually change your catheterization code until you hit the IVC, which would be a 36010. So that means it's a 36005 all the way up the extremity until you get to the IVC, or you would have to come off of the path, that main path there, going up the extremity and, take a selective vessel, off to the right or like off to the left. So this actually stays a 36005 because this is non-selective up to the level of the IVC. So you're not using 36011, you're not using 36012 going up the extremity. If you were going down the extremity, if the puncture was at the common femoral vein and then the physician is moving the catheter downward, then that's where you would get into using your selective catheterization codes, your first order, your second order. But this access is a 36005. So, and that's going to stay that way. So anyway, going down to the last paragraph, we see again, we have our ultrasound guided vascular access. So we can code that a second time. So I've put the XS modifier on that. Depending upon payer, your modifier may be modifier 59 potentially, or some other modifier to indicate that that was a second puncture. And then you'll also see that I have the catheterization code 36005. Again, I've used the XS on that. Maybe you're not using the XS, maybe it's a 59 or some other modifier for your payer. So what we're doing here is, again, what's going to happen is the puncture's at the popliteal and the physician is still going to be continuing to go up the extremity. Okay, so moving up the extremity towards the IVC. So that catheter code wouldn't change unless we hit that inferior vena cava. Okay, so that cath code is 36005. So I just highlighted, the next statement here. It mentions an occlusive thrombus in the popliteal vein. I found that kind of interesting because it mentions, oh, sonographic evaluation demonstrated a patent popliteal vein. I'm like, okay. I'm like, which is it? Could be just a portion of it is. And that's why it's mentioned. And then again, we see contrast was injected, verifying I was within the femoral vein. So again, based on that, to me, I'm not seeing that as diagnostic. The physician is trying to determine where exactly that catheter is at that particular point in time. Then it goes on to say that the femoral vein was completely occluded with thrombus. It was difficult to cross. And then the thrombus was crossed, and then the physician made the way into the iliac veins, and then contrast was injected. Now, here it's not talking about verification, it actually has findings there. So I did put the imaging codes there for the 75820 LT with a question mark, and then also for the IVC, the 75825 with a question mark, because again, we have the conflicting information in the beginning of the report about whether or not this is truly diagnostic angiography. If I was unable to get additional information and I had to make the call, I would not be coding the 75820 and the 75825 here. For one, the conflicting information I don't know, and for two, documentation in the report is not great as far as communicating that this information was utilized, on the decision to intervene. It's like lacking additional information I would like to see. So I personally would not code them at this point in time unless I knew from some other piece of information in the medical record that they were appropriate, because I feel there's inconsistency in the documentation in this report. Okay, so then after that, we see that using an 8 millimeter balloon, doctor says I performed angioplasty from the external iliac vein through the above popliteal vein to the level of the access site. So the question here is, we have this angioplasty. This is the first means of treating this particular, occlusion. And is it going to be, it's a venous, obviously, occlusion here. So it's going to be coded with 37248 and 37249 potentially. But the question I have in looking at this documentation is this like one single lesion that they're treating, from the external iliac to that popliteal vein, or are they separate and distinct lesions? Because if it's one continuous lesion, then we're going to get our 37248. And then if it's two separate lesions, we're going to get our 37249. So this is something I would go back and verify with the physician. Were these distinct and separate, occlusions that we're dealing with here in these two different vessels, or is it one continuous? So depending upon the answer to that question, will determine whether or not you get the add-on code. And then from there, it says I advanced a 5 French infusion length unifuse across the external iliac vein and femoral popliteal veins, and then thrombolysis was initiated. So day 1 of a venous thrombolysis is 37212. And so notice nothing's changing with the cath code. Again, that catheter is staying in that left extremity. So it's going to be 36005 for both of those access sites. And it's actually a common error that I find when I'm doing audits, that going up the extremity on the venous procedures, the coders want to go to, okay, I moved from the anterior tibial and now I'm going into the other vessels and I'm up in the femoral, superficial femoral, and then I'm up in the femoral and the iliac, so I'm going to use a 36012. But that is not correct. It stays a 36005 until you hit the IVC, or if you were going off, into a branch in that extremity that you initially accessed, then you would go ahead and you could change that catheterization code. So that is case number 1. Getting a sip of coffee before I continue. So as always, you can see that documentation is a very big factor when we are coding. And if you've been watching all the episodes of Wildcard Wednesday, you know that in many cases, I'm looking at the reports and I'm saying, we need better documentation. We're lacking documentation. We need to query the physician. And I always say interventional radiology coding does not have to be hard. What makes it most difficult is the lack of documentation. I don't really feel it's the coding itself. I feel it's how is it documented. I've worked with doctors who have great documentation, very easy to follow. I've worked with doctors that have very sparse information, don't have a lot of detail. I've worked with doctors who have lengthy reports, but a lot of it's not really, important from a coding perspective. And then maybe they're missing some things that I need from a coding perspective. So anyway, so here's another one we're going to look at as well. And so this one I think is going to get a little tricky to follow with how it's documented. But here we have a statement where it says patient presents today for right leg angiography with plans on right external iliac intervention. So here I'm like, I feel this statement is a little bit ambiguous here. And once again, I'd want to go back and look elsewhere in the medical record and see, was it the angiogram is needed to make the decision? Because sometimes when they're having the conversation with the patient, they actually are going through, okay, you're going to have an angiogram, then based upon the results of the angiogram, if we see this, then we, might do this, this, and this. Like these are treatment options. So it could be that it is, diagnostic in nature, but there is nothing in here that is going to indicate that to me. So it's not clear here because I don't know. And then even when I get into the details of the report, there's no further information to tell me that the decision to intervene was based on the angiography. So for this particular case, I would not code the imaging codes based on what we have. So here in this procedure, again, we have a procedure with 2 access sites. So now we're looking at an arterial procedure. We just looked at a venous. And so we see angiography of the right lower extremity. We see IVUS here in the procedure list. And then we have an antegrade revascularization and an angioplasty. That would be of the right external iliac. And then we have angioplasty of the right internal iliac. And okay, let's jump in. So again, with our moderate sedation, we don't have our time documented. So we would want to go back and verify that in the medical record and assign those codes as appropriate. So let's look at our procedure details. So here we have ultrasound guided vascular access for the right common femoral artery. And we have our documentation requirements met. So we're going to report a 76937 for that. I didn't insert the catheterization codes in this report because we're doing a lower extremity. So sometimes I throw them in there and then just cross them out and mark them as bundled, but they're not going to be coded because we're doing the lower extremity procedure. So I didn't put them in like I sometimes do. So if we go down to the next paragraph, it says the angiography was performed, demonstrating that the common femoral artery continues to be widely patent with 100% occlusion of the right external iliac artery. So we have our first important piece of clinical information that we've got a 100% occlusion. So I put the imaging code there with the question marks because again, I would go back and look in the medical record for confirmation about whether or not this was a angiogram with possible intervention if they needed to do that in order to decide how to proceed. If so, then that would be the code. So that's why it's inserted there if you got back and got confirmation. And then from there, we see that the physician mentions that a retrograde revascularization was attempted. So then we jump down to the next paragraph. And because the retrograde revascularization was attempted, was having some trouble over there, the physician says, okay, I'm going to gain a second access at that left common femoral artery. And so there again, we have our ultrasound guidance code supported 76937. Again, I've used excess on that, but it could be 59 modifier or other modifier, depending upon your payer. Then when we get into our next paragraph there, it says that the right external iliac artery was selected. Angiography was performed again looking at that 100% occlusion. And then it also mentions here, there's a moderate stenosis at the origin of the internal iliac artery. Then from there, we now see that the physician is attempting an antegrade revascularization. So our first access was retrograde, and now our second access is like antegrade. And so from here, the physician says that he could enter the lumen of the occluded external iliac artery, but the distal portional was subintimal. Therefore, I elected to perform revascularization with a re-entry device using intravascular ultrasound. Now, as far as assigning an IVUS code here, we have a statement about it here, and then the next sentence, 2 sentences later, it mentions it again about using the IVUS. And so when I'm going to assign an IVUS code, I'm looking for detail about the IVUS. I want to know exactly what vessel did they use the IVUS catheter, and I'm looking for measurements. I'm looking for some type of information attached to that. So based on this report, I would not assign it. I could go back, I could ask the physician. I could also look elsewhere. I know sometimes if you go and look at the flow sheets that they're actually documenting the procedure like on when you're in the cath lab, sometimes you can find information over there. At best, maybe give it a 37252, but I really don't feel comfortable with that. Just the way it's documented, that's my personal opinion. So I'm not going to assign anything for the IVUS in this particular case. So now and so we see that the physician, last statement here, it was a through and through access. So both access sites are being utilized for the intervention. So when you have both access sites being utilized for the intervention, then all your catheterization work is going to be bundled. Because if you remember from, our rules and our conventions for coding these procedures, if you have two separate sites of access and one of them is used for diagnostic angiography, and then one is used for the intervention, then you can code for the catheter through the access where only diagnostic imaging was done. But if you have a situation where they do imaging through one and attempt that procedure through that access, and then they come over and get a second access, and now they're using both and they're doing the through and through because they're both being used for the intervention, you wouldn't code for either one. So we don't end up getting any catheterization codes on this case, which I mentioned in the beginning. So if we go down to our next paragraph, it says a Viabond stent graft was deployed across the occluded external iliac artery. So we knew earlier that we had a 100% occlusion. If we're going up into our report here, remember, so 100% occlusion. And then it mentions the occluded artery. So we know that we have a complex lesion that's occurring here. And so the stent was placed and then angioplasty was also performed. So that's going to end up being code 37260 for a complex lesion. But when this procedure is performed, the repeat angiography shows a good result in the vessel that was just treated, but it mentions plaque shifted into the internal iliac artery, and this was occluded. And then it goes down to the next paragraph. Now through the left groin access, the physician selects the internal iliac and then inflates a balloon there in the common iliac artery and was able to advance the balloon across the occluded origin of the internal iliac artery without much resistance. So here I have 37255 add-on code versus 37257. The reason I have that is because if we go back and look at the information that we had on the internal iliac artery, it initially said there is a moderate stenosis at the origin of the internal iliac artery. So here I would say that it's a straightforward lesion, but when we come down to this other paragraph, now the physician is using the word occluded. So my question would be, okay, is this a true 100% occlusion that the resulted? Now we started with a stenosis, but possibly it's now become an occlusion. So that's why I have the 37255. That would be for your straightforward lesion. And then the 37257 would be if this was actually a 100% occlusion. So this is something I would, inquire of the physician about to see if that had changed from just being that straightforward stenosis versus this 100% occlusion. Occlusion, again, clinically speaking, when a physician says occlusion, it means the clinical definition of occlusion is 100%. But here I'm just questioning it because I know sometimes the physicians will use the word occluded when it's not 100%. And because we had that statement of that, straightforward stenosis earlier, I'm not going to feel fully comfortable changing that to complex unless I have confirmation there. And then after that, it says repeat angiogram demonstrated that the plaque has shifted and now the internal iliac artery was open. However, I was concerned the plaque was now partially covering the origin of the external iliac artery stent. So then there was the angioplasty of the external iliac artery with a balloon. So that there we've already coded for the intervention in the external iliac artery, which was a stent and an angioplasty. So we're not going to code anything again because it's actually the same vessel. So there's not going to be any additional coding for that particular part of the procedure. So that is it for our cases this week. So these were fun because of the documentation. So again, I would encourage you to keep sending in your cases. I do need, some more to keep in the queue. Like I said, I believe I have one left to cover. So if you could send me some cases, so I can do 2 next week and keep doing 2 every week. I'd like to keep that cadence. I know I've missed some weeks, but some weeks are just crazy. And sometimes it takes a little time to dig into these cases. Some are really quick for me to code, and then others I'm like, okay, I question myself. I go back and forth on documentation, which I'm sure many of you do when you're reading a report, you read it and you're like, okay, this is what I have. And then you go back and read it again. You're like, well, now I don't know. And that. So anyway, whenever in doubt, always query your physicians. And explain to them why you need the detail. I think if you can show physicians why you need it and show them in dollars and cents why it matters, and then it's a little bit easier to get some cooperation and maybe changing some of the documentation practices. I would encourage, and I'll repeat, I've said this before and I'll say it again, I would encourage physicians to, in the beginning of the report, actually put together like a brief history describing the prior imaging. And if you can get your physicians using language in the reports letting you know that the decision to intervene was based on the imaging, then that's very helpful. But as I've mentioned in past episodes, I'm always very cautious about providing sample language to physicians because I don't want to see it dropped into a template and just carried forward on every patient, because it is going to be based on medical necessity and it's going to be based on every individual case. It is not just verbiage that should be plugged into a template, with the decision to intervene being in there when that actually may not be the case. It does depend upon prior imaging. So thank you for tuning in, and I'll be back next week with some more cases. Thank you.